Good afternoon. My name is Francisco Carmona. It's a big pleasure for me to open this Seud web symposium on the use of the robotic Da Vinci system in treating, surgically treating endometriosis. I think we have today with us three very great experts on this field, and they will share with us their knowledge. I will thank Intuitive for supporting this Seud initiative, because my opinion and the Seud's opinion is that we need to improve our surgical treatment of endometriosis, and we need to explore all the possibilities that we have for giving a better care to our patients. With us, we have today Dr. Thiers Raimundo. He is from Brazil, from the University of Rio de Janeiro, and he is the president of the Brazilian Society of Laparoscopic and Robotic Surgery. He is honorary member of different laparoscopic societies all over the world, and he has a big experience using the robot in endometriosis cases. We have also with us Professor Emile Daré. I think he doesn't need any presentation. He is president of the experts center in endometriosis and the research team on endometriosis, and also the group of research in endometriosis, the research group of endometriosis in the Sorbonne University in Paris. And we have also Professor Gaby Mobat from the States. He works at the George Washington University School of Medicine, and for sure everybody knows him also, and he will translate to us his experience using the robotic system. We have a very, very short time. We have just 1.5 slot for this webinar, and we will go ready for the presentations. And I will ask to the three speakers, please try to be very strict with the time. Yes, we have 20 minutes for each of you, and with no more delay, please, Thiers, if you want to start with your presentation. The presentation of Professor Raimundo is try to answer a very important question. Why managing deep infiltrating endometriosis with Da Vinci robotic system and not with standard laparoscopy? Go ahead, Thiers.
Thanks, Professor Carmona, and I'd like to thank Intuitive and Seud for giving me this pleasure to share this symposium. And I wish to say why managing deep infiltrative endometriosis with robotic system in 20 minutes. It's my first challenge, because I would have many more information to share with you, but I'll try to do this to give you this information during this time, and of course I'll stay after the other presentation to discuss about any doubts or any moral consideration that I could not speak here. So no disclosure related to this presentation. I'm not an official speaker for Intuitive, so it's one more reason to say that how I like the robot by myself. So our roadmap, I'll talk a little bit about some general considerations. I'll talk about the vision, of course. Every time we talk about a robot, we talk about the vision, the motion, articulation, how to use the space, and a little bit about the nerves. When we talk about endometriosis, it's especially important to talk about the nerves. First of all, I'd like to start saying something, because every time we talk about the robot and technology in general, people say, "Oh, I'm a very good surgeon. I don't need technology." And of course, I have to agree, in part because, of course, the most important thing in the OR is the surgeon. The surgeon skills, of course, it's very important. We cannot say the opposite. But what we have to understand is that we can have your skills and add technology, and you can become a better surgeon. And it's not a fault for everyone. We can always become a better surgeon every day. And another important thing is that when we talk about the robot, is that we always try to fight between robot and laparoscopy. And you have to remember that our residents, and I can say in Brazil, for example, we don't have too many surgeries, MIS surgeries during the residence, unfortunately. And so they start to do open surgery. And when they try to start the MIS career, we know that laparoscopy is hard, it's difficult. Of course, I have been doing laparoscopy for many years, but we know that it's difficult. We need to be a very skilled surgeon, especially when you're trying to approach deep endometriosis. And what I can say is that when you go from open to robotic, if you start today trying to start laparoscopy and try to start robotic, the name of the company is very nice because it's very intuitive. You feel the motion. You feel how to act. I always say, I always compare. You can put a stitch inside an abdomen, and if you have a student or a resident and he's starting laparoscopy and robotic at the same time. If you don't say anything, any advice, the resident in robotic will suture. In laparoscopy, he will struggle a lot because with the robot, he can feel the movement, and it's much easier to understand this concept when you're trying to start your practice. And people always asking me, but robotic, oh no, it's not a static procedure. You have so many arms and the incisions are bigger and higher. And this is just a case that I performed like 10 days ago. And if I showed you this picture without saying about anything, you would say that it's a laparoscopy surgeon. And that's what, and this new platform, the XI platform, is so nice because we can work like this with lower incisions and feeling like you just did a laparoscopy case. So it's not an excuse to avoid robotic because I'm aesthetic. And I work in Rio de Janeiro, Brazil. So my office is so close to the beach that I cannot say to the patient that I'll put just higher incisions with bigger incisions, and I can do this with robotic. It's not an excuse. And even in simple cases, I can avoid my assistant and you use the robotic with one incision in the umbilical and two incisions below like this. So down like this. We don't need to put higher. Of course, if you need, it's a big uterus or big myomas, it's another case. But in simple case, you can even avoid your assistant to do your procedures. And didn't talk about the SP, the single port platform. We are just starting in Brazil. Unfortunately, we don't have yet any platform, but soon we'll have it here, and it will be even more comfortable to do a static procedure with the robotic advantage. Another important difference between robotic and other laparoscopy or other approach that we have to think about traveling and teaching. And I travel Brazil and the world to do robotic like Gabby, like Professor Darai. And you know that XI here in Brazil is the same as in France, is the same as in Lebanon. I put the Lebanon flag to please my friend Gabby. And wherever you are in the world, you know XI platform is the same. So it's very comfortable for a surgeon that is traveling to teach or to do a surgery in another country, another state, that you will find the same platform also. It's different when you are trying to do an open laparoscopy. You have to ask, oh, but you have this kind of instrument, you have this kind of the HD platform. With XI, you don't need to ask this because they are all the same. Let's talk a little bit about the vision. And of course, it's unfortunately we cannot broadcast in 3D, but it would be nice to broadcast in 3D. I will show a lot some videos in. You have to try to think the video in 3D because it's much better when we see. And so this study comparing the two groups, and they randomized it. They starting to look at the pelvis with 2D and then 3D, and the other group started with 3D and then changed it to 2D. And what they found in the studies, that they found more endometriotic lesions with the 3D scope. And also the group that started with the 3D first, they improved when they analyzed the 2D after the 3D. So it shows that with 3D, although we are very skilled surgeon, we can see a lot of endometriotic lesions, the 3D helps us to improve our visualization of this kind of lesion. And also with the ICG, we can improve. We know that now we can use the ICG for laparoscopy, but with XI, we know that it's standard. We have Firefly. We can use ICG technology in every case. So we don't need to ask if you have a laparoscopy set with ICG. And see how the difference. This is a picture to show you. Of course, when you are dealing with the 3D vision and ICG together, it's much easier to identify more lesions, and that's why this study showed this kind of difference. And I want to show you this video. This is a sciatic approach, a sciatic endometriosis approach. And again, I cannot broadcast in 3D, but I want you to imagine all these structures, one below the other, and you're watching this in 2D. It's amazing. There's not a single surgeon that when I invite to look at the console and say, "Wow, oh, what? It's a total different surgery." So you can see all the structure, the lumbar sacral trunk, obturator nerve, and when you look at this in 3D, it's much easier to identify. And again, I know that in 2D, I do this kind of surgery with laparoscopy, but when you see this, when I ask my assistants to come to the console and take a look, say, "Oh no, it's not fair. You are doing a different surgery. It's a different patient," and it's true. It's not a single one says a different word. And let's talk a little bit. So vision is good, but let's talk a little bit about some articulation and use of space. And I think the robot is very, very nice in this kind of situation. So what I was saying is that in this first slides, that we imagine look this in 3D with all the structures one below the other, and we can see that the distance is much more real for us doing the surgery. So what I was saying, that's when I ask an assistant to look at the screen in compare with the console. When they take a look at the console, say, "Oh, it's not fair. You are doing a total different surgery." That's why we ask sometimes that you are too close to the structure, or we are not seeing what you're seeing. So it's very, very different when you are using the 3D. Go ahead, please. So in this video, I'd like to show you how suture is very, very good with the robotic approach, because we can handle the needle and going from cranial to caudal, cranial, and with the right hand, with the left hand, almost doing the same. Even if you're a right-handed surgeon or left-handed surgeon, it's very good. It's very good to suture and to do the movement, and even it's better with these like small structures. Look, when you are suturing a ureter with the laparoscopy, sometimes of course we can do it, but it's hard to do this movement of the small structures, and now with the robots, it's so fine to perform. Go ahead, next slide, please. Let's go a little bit faster because of the time, because we have this problem with the slide. Again, no, this is the same video. Again, next video, please. And this is a robotic ureter reimplantation. and you can use this again, a lot of suture and dissection and motion, articulation in order to improve the benefits of the robot. See how we can change the articulation of the instruments in order to dissect below the structure. So it's very nice. You can fast forward a little bit the video, please. You can put almost at the end of the video, so we can show you the reimplantation. And it's a procedure that we have to suture a lot. So it's very nice when you have this kind of procedures and you have the robot to help you to suture. Again, you can fast, next slide, next video. This is a very nice case. It's a sciatic endometriosis case. And I want you to take a look at how we can work in tiny space. And in general, I don't use the fourth arm, but in this case, I was with the resident. And so it's other advantage of the robot. You are more independent, a surgeon. So in this case, I put the fourth arm in order to help me. And you're gonna see that how I will use the fourth arm. First, with the scissor, I will articulate in order to dissect the vessel. And in a few seconds, you're gonna see that I will use the fourth arm in order to expose, to improve my exposure of the sciatic nerve. This is the sciatic nerve over here. This nerve that you are seeing on the screen. Now it's the sciatic nerve. So it's very, next slide, please. Let's move on because of the time. Now you can, it's just almost the same. Let's move on to the other slide. I was just talking about and just show this video over here. On the right side of the screen. This is the diaphragmatic endometriosis, and I put this video comparing the laparoscopic approach, how we change the position of the screen, and with now you can start the video on the other side of the screen. And with the robotic approach, we are doing this inside the thoracic cavity, and you can see that in tiny space you can work with the robotic approach, and even losing your vision and your articulation and motion. Next slide, please. A little bit. Next slide, please. This is a randomized La Rosse study. It's a very famous study comparing robotic and laparoscopic approach. Next slide, please. And they showed a little bit advantage of the robotic, but only the numbers were not so amazing because we are just starting with our robotic approach. And I have no doubt that in the future, with our experience, we're going to improve the robotic results comparing to laparoscopy. Next slide, please. Next slide. I will skip this. It's almost the same situation. Next slide, please. And next slide. This is a study showing the robotic approach of prostate cancer and comparing open and laparoscopy with robotic. And okay, go ahead. And about incontinence, and again, go ahead. And also this study is a robotic approach. Again, next slide, please. It's a robotic approach, those studies. It's a robotic approach about prostate cancer and bowel cancer. And they improved about incontinence and impotence, comparing the nerve approach used the robotic. And I think if we're going to have more time in the future and more cases in the future, I have no doubt that we're going to improve this kind of approach, a robotic approach, in order to treat the nerves, because we can see better. We can see the boundaries between the nerve and the normal tissue. And I think we need just more time and more studies. And maybe in the future, we together, Carmona, Gabby, and Professor Darai, we can do a multicentric study in order to show these advantages of the robotic. Next slide, please. So my take-home message is, you won't know, you won't try if you don't try. So sit at the console, and then after you can say something about the robot. And this is my experience. Every time I start to teach a surgeon, when they sit at the console, they say, wow, I was not expecting this. I thought I was studying robotic just for commercial-ish things to help me with my marketing, but I didn't feel like this, watching 3D with this motion, with the use of space. And of course, sorry for this presentation. I updated my presentation with nice videos, but it's okay if during the discussion I can help with show another video if it works. Okay, so again, thanks for the opportunity, and you can put your next slide, please. So these are my contacts. So you are free to contact me if you want to discuss anything about robotic approach, and in the future also for collaboration. So thanks again for the opportunity. Sorry for this, but surgeon has to deal with complications, and it was okay. Thank you.
Exactly, dear. Surgeons have to deal with complications, and you have solved perfectly the complication. I want to thank you because you were exactly on the time, even after the complication. So thank you again. Very nice presentation. Congratulations. And now is the turn of Professor Émile Daré from Paris. The topic of Professor Daré is can robotic make a difference when we are operating wobble endometriosis? Please, Émile.
Yes. Do you listen me?
Yes.
Okay.
Yes.
So
the answer is yes. Try to explain us.
Thank you. First of all, I would like to thank the committee of organization of this webinar for the invitation to speak on bowel endometriosis. Can robotic make a difference? Great question. As you know, endometriosis is a very frequent pathology affecting patients of the female population in 5 to 10%. The incidence of bowel endometriosis is thought to affect about 5 to 12% of patients with endometriosis. Among bowel endometriosis, colorectal represents the main location. According to series, 85 to 95% of the surgery for bowel endometriosis. Surgery is recommended when there is a failure of medical treatment or in case of infertility, often after 2 IVF cycle failure, although we have some data suggesting that the first intention surgery is a good option for enhancing pregnancy. Classically, surgery consists in conservative surgery, including both rectal shaving and discoid resection, or radical treatment based on segmental resection. So far, what do we know about colorectal endometriosis and surgery? You have 194 articles on laparoscopic management of colorectal endometriosis. We have only 22 articles on robotic surgery and colorectal endometriosis. Only one comparing shaving to segmental resection, and no trial comparing robotic to conventional laparoscopic for colorectal endometriosis. So in 2017, the French guideline for the management of endometriosis stated that there are insufficient data to recommend robotic access for colorectal endometriosis, and the recommendation was relatively simple. Robotic assisted surgery is an option for the treatment of deep endometriosis with bowel involvement, but with a weak evidence. Recently, the Italian Club of Endometriosis published 10 recommendations for the management of endometriosis. And the last one was, do not use robotic-assisted laparoscopy for endometriosis outside research setting. But in fact, there is two crucial issues. First, the learning curve for robotic surgery, and especially for colorectal resection. We have so far only one study from Bokhari, published in 2015, evaluating the learning curve with a phase 1 initial experience with a robotic, including at least 15 procedures. Then a phase 2, including 10 additional procedures. And finally, a phase 3 corresponding to surgeon with adequate formation for colorectal resection. But it is very important to note that this learning curve was based only on operating time and not complication. Moreover, in this study, the main indication was cancer or inflammatory disease. The second crucial issue is who can make this surgery. Sofiane Bendifala in our department evaluated the relation between complication, and especially post-operative complication of colorectal endometriosis, and hospital volume per center and per surgeon. As you can see on the left, you have a diagram demonstrating that at least 20 procedures should be performed per center and per year for decreasing the risk of complication. On the right, you can see for a surgeon, he should perform at least 8 to 13 procedures of colorectal resection to decrease the risk of complication. This issue is crucial. Why is it crucial? Because when you see the literature on robotic surgery for colorectal endometriosis, you can see that among authors that have published their experience, no one except Horace Roman have reached the level 3 in robotic surgery or published this. And moreover, you can see that no department developed surgery for colorectal endometriosis treated by robotic with enough cases per year. When you analyze this literature, we can see that Roman in 2020 published a retrospective study on 1 year, including 491 procedures for colorectal endometriosis, including 28 performed by robotic, but no data specific to this approach was available. Previously, Horace Roman published in 2017 a retrospective study in France, including 56 centers with 1,135 colorectal resection, showing that 9.7% of these procedures were performed by robot. But no possibility to evaluate operating time or complications specific to this subpopulation was available. Finally, we have only the data from Bala, that was a meta-analysis on 3,000 cases, showing that robot was used only in 1.7% of all colorectal endometriosis. What can you see? We can see that operating time was higher for robotic surgery, but without difference between open and laparoscopic approach. When considering blood loss, this was higher for open surgery, but similar between laparoscopic approach and robotic approach. But the most important is the evaluation of complication, post-operative complication. You can see on the slide that open surgery was associated with a very high risk. 1/4 of the patient had postoperative complication. This was significantly higher than that observed for laparoscopic approach and robotic approach. Even there is no difference between these two later groups. Interestingly, even there is no significant difference is the rate of rectovaginal fistula. You can see that this rate was not different between open and laparoscopic approach, but the rate was 7.4% for robotic. In 2020, we published our initial experience in robotic on 6 months on colorectal resection. As you can see, there is 2 small groups, one of a robotic group, including 23 patients, and another one, a conventional laparoscopic group, composed of 25 patients. It is very important to note that there is no preoperative selection of the patient. It was only depending on the availability of a theater. In this preliminary study, probably due to the small sample size, we only demonstrated that there is a difference in operating time that was higher for a robotic group, while no difference in intraoperative surgery complication, postoperative complication, hospital stay, and voiding dysfunction was observed between the group. Now we extended our experience in robotic surgery for colorectal endometriosis from March 2019 to December 2020. It is important to note that our department have a relatively high recruitment in colorectal endometriosis with about 100 procedures per year. All the 3 operators, Sofiane Bendifala, Cyril Touboul, and me, have reached the phase 3 level of learning curve. And there is a specificity in France that we have all the digestive qualification as well for gynecologic surgery. There is some limitation of our experience due to the availability of the robot once a week and twice a week every 2 weeks. The second element is the limitation related to the COVID-19 pandemic with an interruption of the surgical activity during 3 months and an additional month of interruption during the second pandemic period. So I will present you our experience on a relatively short period of 18 months. When we compare the epidemiological characteristic of our population composed of 61 patients in the robotic group and 61 in the conventional laparoscopic group. As previously said, there is no preoperative selection of the patient, only based on the availability of the robot room. No difference in epidemiological characteristic was found between the group. No difference in preoperative evaluation of the disease by MRI and Zion classification, and no difference in indication for surgery. The sole difference between the group was a higher rate of rectal endoscopic sonography in the robotic group. No explanation. What about the characteristic, surgical characteristic? You can see, as in the first publication, the operating time was higher in the robotic group, regardless the type of surgery, compared to conventional laparoscopy. no difference in intraoperative complication, no difference in blood loss, in postoperative complication, no difference in surgical revision and voiding dysfunction. More interesting, very interesting, was the rate of free margin. It was very interesting to note that 95% of the patient had free margin digestive resection, suggesting potential and relevance of magnification of the vision. The second one, even we have not a significant difference, is the shift from segmental resection to discoid resection, simple or double discoid resection. Another very interesting data was the low rate or lower rate of protective ileostomy in the group of robot. This is not due to the selection of the patient that has the rate of hysterectomy, bladder resection, or other surgeries such as partial colpectomy were similar between the group. But it is important to analyze the results with another point of view, taking into account the type of surgery, shaving, discoid, and segmental resection. Of course, we found a difference in operating time according to the procedure, higher for segmental resection compared to shaving and discoid resection. Blood loss was also higher in the segmental resection. But we see also a difference in hospital stay, while no difference in the complication rate and in voiding dysfunction was found between the group. But the main issue is to compare the robotic group with conventional laparoscopy group, taking into account the type of surgery. So, as previously said, there is a conservative surgery composed of shaving and discoid resection, and on the other side, the radical surgery based on segmental resection. As you can see, for conservative surgery, there is effectively a higher operating time for robotic. But when you consider only the segmental resection, you can see that there is no difference between the two groups. So it's maybe a good option for this type of surgery by a robotic. Interesting also, even the difference was not significant, is the rate of operative complication. That was only 4.8 in the robotic group and 17.9 in the laparoscopy group, composed mainly of bladder injury, opening of the vagina, or vessel injury. Another very interesting data, even not significant, is the rate of voiding dysfunction lasting more than 1 month. As you can see, it was only 9.5% versus 17.9%. As Raymond said previously, probably this is due to the better evaluation of nerve distribution during the surgery. And after, we decided to make another analysis of our data. We compare in one group composed of robotic patients who underwent either discoid resection or segmental resection, and the same for the conventional laparoscopy. Something is very interesting is the low rate of intraoperative complication in the robotic group, while no difference was observed for the total morbidity and hospital stay, and a trend for lower avoiding dysfunction in the robotic group lasting more than 1 month. So what are our reflections about robotic surgery for colorectal endometriosis? Of course, there is a trend for a higher rate of discoid resection in the robotic group, but this is probably due to the switch of some patients scheduled for first segmental resection into this resection. Probably the magnification of the vision is one major cause of this switch. There is also a relevance of robotic when requiring associated procedure, such as bladder resection, hysterectomy, ureteral resection, or reimplantation. And as previously said, probably a better identification of the nerve and probably a benefit on bowel function and also on the risk of long-term voiding dysfunction. So you can see that there is a higher operating time for robotic surgery for rectal shaving, but not at all in the group composed of patients who had a discoid or segmental resection. This is probably the better subgroup of the population that could be used for future trial. Higher free margin for robotic surgery, a lower intraoperative complication for robotic, but no difference in the morbidity between the group. Finally, what can we say? There is cumulative data suggesting the advantages of robotic surgery for colorectal endometriosis, but there is a need for trial, non-inferiority test comparing robotic and laparoscopic surgery with, as mentioned previously, better evaluation with a number of patients relatively low when considering the group of patients undergoing segmental or discoid resection. And there is also a need for medico-economic evaluation taking into account surgical room occupancy, hospital stay, and recovery time. Thank you for your attention and sorry for my English.
Thank you very much, Emil. Your English is perfect.
Thank you.
Now is the turn of after this amazing presentation of Dr. Dare, congratulations again. Is Professor Gabi Moabat with a very important topic that is how to standardize the technique when you are using the robotic for the endometriosis treatment. Gabi, go ahead.
Thank you for Seud and Intuitive for this great opportunity. Today I will be talking about standardizing the endometriosis excision with the Da Vinci technology. We created a mnemonic, the SoSure technique that we're going to go over. My disclosures, I'm a speaker for Intuitive Surgical. The objectives of my talk today is to review the SoSure standardized approach for endometriosis, especially for posterior compartment endometriosis, discuss the value of each of the important steps of the approach, and highlight the added value of Da Vinci surgery in simplifying these complex procedures. So many of my fellow professors talked about the value of robotic surgery, simplifying it into vision, a multidisciplinary approach, and the assistant. The value of multidisciplinary is really important when you have multiple teams like colorectal surgeons, thoracic surgeons using the same platform to make an optimal surgery and a complete surgery for a patient. And then the value of the Da Vinci that we don't talk a lot about is the assistant. Having the multiple arms controlled by the surgeon and the camera controlled by the surgeon will enable the surgeon to do more complex tasks without relying on an assistant, and the role of the assistant will become very rudimentary in those cases. So let's dissect into the suture technique. The S stands for sigmoid, the O for the ovary, the SU for securing the ureter and the uterine artery, the R for dissecting the rectum or opening the pararectal spaces, and at the end, the excision of endometriosis. So there are multiple preparatory steps, and if we can follow that list, we can at least standardize the way we approach endometriosis in a safer way, and it will give you more efficiency during your surgeries. So the sigmoid, it's very important to expose the pelvic brim, avoid the nerve injury, the nerve on the psoas muscle, and mobilize the sigmoid in preparation for a segmental resection if that is needed for a posterior compartment endometriosis. So I'll show you the technique. It's very simple. We do it a lot. Mostly the tips and tricks is to stay above the TODS line and not enter the retroperitoneum at this stage. There are a lot of nerves that goes, even though these are sensory nerves like the genitofemoral, laterofemoral cutaneous nerve, the ilioinguinal and iliohypogastric nerves could be important. But the more important step is to expose the pelvic brim on the left side, because if you run into bleeding or complication, you want to have the surgical field exposed before you start doing backwards the steps. So I start my surgery always with exposing the pelvic brim on the left side and then dissecting the sigmoid in preparation. And you can go up, even with the XI technology, you can go up to the splenic flexure and dissect the sigmoid if you're planning to do a segmental resection. The second step is usually the ovaries are in the way. If we have an ovarian endometrioma, we like to remove it and then transfix the ovary to the round ligament. To expose the ovarian fossa, which is one of the more common sites of endometriosis, peritoneal endometriosis, to avoid ureteral injury if we have adhesions of the ovary to the peritoneum and the ureter is retracted, and then facilitate the sidewall access. And then with the robotic technology, this will become very simple. We simplify it by using a 3/0 V-lock, a 15 centimeter or 6-inch, and then you are in full control doing that. I know in Europe, they use a lot of different technology that transfix the ovary, but I found this is very simple with the robotic technology. You can take the cephalad part of the base of the ovary and using the same suture to transfix both ovaries. And this is a very simple step that could help you a lot in accessing the lateral pelvic sidewall, especially if you're planning to do a peritonectomy for minimal endometriosis. So as you can see, the suturing is very simplified. The intracorporeal suturing is very simplified with the robotic technology. Now we move to the other step, the ureter and the uterine artery. If we're doing a fertility sparing, the ureter needs to be dissected anyway, but the uterine artery, you don't need to dissect it. If we're doing a hysterectomy at the time of endometriosis excision, then I like to go retroperitoneal to prevent the intraperitoneal adhesions. The ureter is very important. It could be easily retracted, and we can never trust the transperitoneal location of the ureter during endometriosis surgery. And then the uterine artery will enable us to have a full control of the blood supply of the uterus during a hysterectomy concomitant with endometriosis resection. So here, this is a posterior approach of dissecting the ureter. Always we start at the pelvic brim, we score the peritoneum, and then we identify the ureter at its most shallow location, if I can say. And then you carry on. There is an endometriosis lesion now down closer to the uterosacral here. So when we do peritonectomy for endometriosis to ensure a complete excision of the disease, dissecting the ureter will become a very simple task. You can see that minimal energy is used, and all what we're trying to do is trying to use a monopolar energy and push away for the ureter from the posterior leaf of the broad ligament. In that video, we'll showcase how it is easy to identify the pars nervosa and be able to spare that during endometriosis excision. You can see here the ureter is dissected away from the posterior leaf, and we can see and identify the deep uterine vein, and the pars nervosa will lie below the posterior to the deep uterine vein, and this is the inferior hypogastric plexus, and this is very important to spare before you excise endometriosis. So this is the more anterior approach when we have to dissect and open the retroperitoneum. If we're deciding to do a hysterectomy, what will happen is we score the anterior leaf of the broad ligament parallel to the IP. Again, we identify always the ureter at the pelvic brim, and it is not uncommon that the ureter is retracted with the IP during endometriosis cases. Being very familiar with these spaces will enable you to have a better control of endometriosis surgery, because it's crucial to be accustomed to these spaces to perform more complex surgery in a safer way. So as you can see, the same technique we used for the ureter, and then we developed the paravesical and pararectal space. This is a very important landmark to identify the medial paravesical space and avoid entering the obturator space if no need. And as you can see, a full control of the camera with the surgeon, and the articulated instrument that can work with precision surgery in very narrow spaces will enable you to identify uterine artery here, as you can see, and be able to secure it safely during your procedure. Now, the pararectal space, especially the medial pararectal space, the Okabayashi space, is a very important landmark in endometriosis surgery. It carries all the somatic nerves, and avoiding those somatic nerves will enable you to have a better outcome, especially when we're talking about urinary or bowel problems following the surgery. And it centralizes the disease, it facilitates the deep infiltrating endometriosis resection. The few tips and tricks when dissecting the Okabayashi space. We start really high many times, and the most important tip is to stay in contact with the mesorectum, because this is the only way that you can avoid nerve injury if you're not familiar in dissecting those nerve injury. So you can see here now the yellow, which is the mesorectum, and then maintaining your dissection closer to the mesorectum, especially when you start going posterior to the ureter. And this is when you start encountering the pars nervosa below the deep uterine vein. And this is a very crucial and important step in dissecting. As you can see here, we start seeing the nerve fibers of the inferior hypogastric plexus and sticking to the the contact of the mesorectum will avoid you injuring those fine structures and fine nerves. And this is one of the advantages of the robotic platform is the vision. You can easy see those fine structures and be able to do very fine movement to avoid avulsing those nerves and providing a better nerve sparing surgery and better functional outcome for your patients. On the right side, it is very similar, opening the Okabayashi space. The same trick will apply. Stay in contact with the mesorectum until you get to the uterosacral. What I like to use when I get to the uterosacral, I like to use a rectal probe to enable me to identify the borders, delineate the borders of the rectum, and especially in deeply infiltrative endometriosis case. Here we can see we have an endometriosis nodule, and that will enable you to be more aggressive on excising the disease. Here the meso of the rectum is infiltrated with endometriosis. So knowing where are the borders of the rectum will enable you to aggressively excise the disease without rectal injury. So, and this is a pelvic anatomy slide to just showcase the landmarks that are very important in deep endometriosis excision. You can see here the ureter, you can see the hypogastric nerve, the uterine artery, and the deep uterine vein below the uterine artery, and the pars nervosa and the left hypogastric nerve is deeper. And you can see how easy to avulse that structure or to injure that structure during an endometriosis excision. The value of the vision and the precision surgery will enable you to spare those important structures. I'm going to skip this one. Here you can see how close is the inferior hypogastric, the left hypogastric artery, and that's why the tip of sticking in contact with the mesorectum during the dissection will enable you to spare those nerves. Not every time we are able to spare those nerves, but it's always important during deep endometriosis surgery to identify those nerves. You don't need to dissect them all the time, but it's important to identify them to enable a full excision. Here you can see we have a nodule on the bowel, and then after centralizing the disease and opening the bilateral pararectal spaces, this is when we are able to start separating the disease and transecting the nodule in two. One portion would remain on the vagina and the other portion would remain on the bowel. So it will make it easier to excise both portions at the end. And as you can see in most of the surgery, the role of the assistant is barely non-existent. Is either to grab a structure or to pull away a structure, and that could be done by the fourth arm as well. So after we open the retrovaginal space or pre-rectal space, we have the vaginal nodule and the uterosacral nodules, and then the rectal nodule that we separated. The last step, which is excision of endo, will become the easier step after you dissected all the important and valuable structure. And then this is the goal of the surgery, basically, but there are a lot of preparation. And if you can follow those initial steps, you can standardize the way you do surgery and you can increase your efficiency. There are a lot of strategies, shaving, disc excision, and segmental resection. And I want to make a note, since we started doing robotic surgery, we tend to do less invasive surgery, like shaving is more than discoid excision, and discoid excision is more than segmental resection, because of the ability to be able to do a very precise movement with a robotic platform. Here I'm going to show you a case of a shaving, and then you're going to see how much precision you can do even with deep mucosal shaving, where you have the mucosa only aligned. I have a rectal probe. I put a stitch on the nodule for easy manipulation of the nodule, and that's a V-lock that I will use to suture the muscularis of the bowel at the end. So you can see here, we use cold scissors when we start shaving. The rectal probe will enable me all the time to see the mucosa, if I can say. And then the scissors and the suture that I place will enable me to manipulate better the nodule on the bowel. And you can see we adjust the rectal probe all the time so we can be able to see the mucosa of the bowel and avoid penetrating. And if we did penetrate the mucosa, that will become a small discoid excision rather than a disc shaving. But having the ability not to enter the mucosa will enable most of our patients to go home the same day after these surgery. And then when we do shaving, there is a lot of use of the word. People think that we're suboptimally taking the disease. The purpose of shaving is to excise completely the disease without entering the bowel lumen. So here you can see we did that shaving with the mucosa intact, and then that same suture that we used to hold the nodule, we'll use it again to close the nodule to increase the cost efficiency of that procedure, and it's a VLOC 3.0. And then as you can see, the suture, especially in those tight places, will become very accurate, very precise with the added value of the Da Vinci platform, especially in suturing. And as you can see at the end, the final end of the surgery is you have an approximated, well-approximated muscularis using the types of sutures, braided sutures, will enable you to have an adjusted tension on the tissue and minimize the blood constriction. So theoretically, that will decrease the chances of necrosis and the chances of fistula in the future. In this video, you don't see, but usually we do an ICG injection with a Firefly to see the perfusion of that incision, and that was shown in as a phageal anastomosis that it will decrease the chance of fistula on the future, and this is something for the future to be evaluated with a robotic platform. Again, here we'll showcase a little bit a disc, transanal discoid excision, where we use a suture to take the caudad and the cephalad part of the disc, and then we insert transanally a circular stapler where we can push the nodule, especially after shaving, within the between the anvil and the circular stapler, and that will enable us to do a discoid excision. And then even in that case, we did do a double discoid excision, which is not uncommon if you have a larger disc. And then having that full control deep in the pelvis with the robotic platform will enable you to excise fully the disease at the same time with more time efficiency. And I know the impressive numbers that Professor Darai published, and this is biased because they did thousands and thousands of laparoscopic surgery compared to their initial experience in robotic surgery. At the end, the take-home point, endometriosis excision is a complex surgery. It requires a pre-surgical clear plan. The SoSure approach helps simplifying the steps and enable a better standardized technique for the surgeon. The Da Vinci surgery enables the surgeon to simplify the complex endometriosis excision. So that was my talk. Thank you very much again for the opportunity, Seud and Intuitive, and then thank you for my co-fellow presenters.
Thank you, Mohamed. A nice presentation. Thank you for all the speakers. You have outstanding presentations, and now we have time around 20 minutes for discussion. There are some questions from the audience. The panel is open for the questions. So if you want to put your question in the chat, I will be able to translate it to the speakers. Just to start the discussion, I have some questions for all of you. What will be your advice for the laparoscopic surgeon who is prone to start with the robotic? What is the advice of you? Which cases for starting? Which is the best way to gain experience to overcome the learning curve? Yes, you were the first. You were the first in answering.
Of course, like always, when we are learning, I advise to start with simple cases or cases that you need some dissection, but it's not a freezed pelvic, because you need to be skilled to dissect, like Gabby showed, like the case that I showed. If, for example, if you start with a sciatic case, of course, you won't succeed because you're just starting to deal with the platform, the robotic platform. So you start to case with some case that you need some dissection, but it's not a free pelvic. frozen pelvic, because otherwise you're gonna feel discomfortable, and then you're gonna blame the robot for not doing the right case, and then you won't be a robotic fan or robotic surgeon. So try to start with a simple case, and then and then schedule some for more complex cases. And another advice is that do not. It's difficult during the beginning, but do not try to put some laparoscopy movements in the robotic surgery, because it's funny, because when we are starting to work with the robotic, we go like straight sticks, because you are so used to do laparoscopy that you try to do the same. And you have to remember that when I showed the videos, and like Gabby, one of the events of the robot is just is this kind of articulation of the instruments, and you have to try to remember to use it all the time, because you can just pull some structures, open your space to work, and when you do it, you can work in a small space. I had one video in my updated presentation. It's a correction of a rectovaginal fistula using the robot. And it's so nice because it's so tiny space, it's so deep in the pelvis. And in small space, you can suture, you can dissect, and with the straight sticks, so difficult. So, of course, to let Gabby and Professor Wright to speak, I would say the good advice.
Yes,
Emil, you are finishing your learning curve, I saw in your presentation. What is your advice? But try to be direct.
For me, it's very difficult to select this type of surgery in the beginning of experience in the robotic. Of course, it seems logical to begin by very simple surgery, but in fact, in our department, we have only the possibility to use a robot very small. So you had to begin very quickly in major surgery. As said, Gabi, when he came in Paris, he said there is a big surgery for the beginning, and I agree with this comment. But you make a choice. This choice is not to allow to all the surgeons of the department to make a robotic surgery, but some with a relatively high experience in laparoscopy to switch to robotic. So when you begin our experience, we said, we restricted the robot for major surgery, colorectal resection, and cancer. It's maybe not a good option, but the availability of the robot, it's a major issue in our hospital. So it was very important to learn very quickly the manipulator of the robot to have a good how to say rendement
return.
Thanks, Gabi. It's very important for us and also for the hospital. That's because it's not logical to perform salpingo-oophorectomy by a robotic. Even it's easy. It's simple surgery. It's maybe better to choose some surgery who make that are a great...
I totally agree with you. I have exactly the same problem that you describe. In my availability for the robot is once per week at maximum, maybe once every 2 weeks. So we need to go very fast to the big cases. We have not time to lose with if we have the robot, we cannot use a very simple hysterectomy. No, we need to, I think it's Thank you. Mohammed, what?
Maybe Gabi, a comment for you, because I'm very happy to see your presentation. It's very simple, and I share completely this vision of the robotic use. Thanks.
Thank you. No, I think, to be honest with you, learning robotic surgery, even though you had a massive experience in laparoscopic surgery, you have to be ready to be a learner. Because everything you learn for new, you need to be a learner. There is a learning curve. So my advice to the surgeon, look openly to the new technology, leave your ego outside. We know you don't need to prove anything to anybody. You just need to see if that technology will help your patients, improve your patient outcomes, help the patients. If you don't think that is important for you, or you don't think that will do anything for your patient, I don't think you should learn robotic surgery. But if you don't want to learn robotic surgery, do not ditch the technology. Because altogether, what we need to be in one hand to have the goal of improving the outcome for the patients and embrace technology in a better way to improve the quality of life and the quality of surgery that we do for our patients. So I believe robotic surgery is at its infancy, and I think especially in endometriosis, because it takes a laparoscopic surgeon 5 to 10 years to be a great endometriosis surgeon. In robotic surgery, we're ditching the technology with having a 6 month of robotic experience compared to 20 years of laparoscopic surgery. So your presentation, Professor Darai, was an eye-opening for me, because with the major bias of the massive experience that you have in laparoscopic surgery, you could find in that shorter period of time value of the robotic technology. So imagine 5 years from now, when we're talking with a vast experience in robotic surgery, what would be your numbers?
And how do you overcome the problem of lacking the haptic sensitivity? It is so important for the endometriosis just to touch the nodule to feel that it is hard or soft. You cannot feel it with the robot. How you overcome this problem?
Well, believe me, the visual haptic. It's let's take anybody who loses any sense. Let's start about somebody who is blind. They hear better, they smell better, they can feel better their surrounding. In robotic surgery, you develop visual haptics that will enable you precisely to see this is hard, this is medium hard, this is not really hard. With laparoscopic surgery, with the stick, there's no feedback as much as you use with your hand. And even though laparoscopic surgery is still the gold standard now for endometriosis resection. So how are you able to do that?
I like to say that with the robot, we learn to touch with the eyes. It's exactly. And of course, if you have any doubt, what I do is that I ask my assistant to help me. But usually, when you try to learn to touch with the robot, touch with your eyes, usually you know when you cut the tissue, you know if it's a normal tissue or it's hard. And it's just the learning curve, and you increase a lot how, just Gabby said, how your sense of seeing but touching with your eyes.
We have some questions from the audience. I have to recognize that we have a very, very active audience. They are giving a lot of questions. There are some questions about the use of anti-adherent substance. Do you think that robotic makes a difference with the standard laparoscopy in the adhesion formation? You think that robotic is a way of preventing adhesion, so you have to use anti-adherents in the same way that you use it in standard laparoscopy? For all of you.
It's very difficult to answer the question because you have to have some evidences about the efficacy of anti-adhesion barrier. effectively, it seems logical to use this type of tools when you have a goal such as fertility. Even the results are not always as good as found in laparoscopy or in open surgery. So far, it's true that in our department, we did not use every day this type of barrier. Only in very small cases. It is possible that also the bleeding that is relatively limited by robotic surgery, prevention of adhesion. The second point is this desiccation of the tissue by robotic. Then we used a bipolar coagulation by laparoscopy. So there is a need to better explore this kind of fields to prove or not to prove if there is a place for anti-barrier, anti-adhesion tool.
Barriers. I have also another question. That is an open question for any of you about the incidence and the prevention of complications. From your presentations, I understood that there are no more complications in robotic surgery than in the standard laparoscopic surgery. Is that true? Do you think that the complication rate is different in robotics? Is important? Is any specific way of preventing? Or is there any specific complications for robotic surgery?
I think robotic surgery is laparoscopic surgery. So we're trying to compare, we're trying to compare the same thing. Most of the complications are either complications that are arising from the surgeon inherent to the surgery, or complications that are happening after, stuff that we don't do the surgery robotic or laparoscopically. If we suture the disc manually or we suture with a staple, there's complication inherent to those both techniques. But most of the complication, I believe, there are directly related to the surgeon experience and expertise in managing the disease, the experience in using the electrosurgery. And I believe it's not fair to compare the complication laparoscopically and robotic. What attracted me to the Professor Darai presentation, I can tell you by experience, being able to identify the nerves and dissect the nerves if needed is easily done with more control with the robotic surgery than in laparoscopy. And that might prove on the long term that it could potentially help in improving the outcome, functional outcomes of the bladder and bowel after robotic surgery of those. One added value of robotic surgery is the ICG or the Firefly, which now we started using it in very non-conventional ways to look at the perfusion of the Waldeyer sheath of the ureter, for example, to look at the bowels and to see if there are areas of non-perfusion that could be related to thermal injury, and to look at the perfusion of anastomosis. And it was not proven for GYN surgery, but it was proven in anastomosis in the esophagus with a trial that decreases the chances of leak rate and then fistula if there is good perfusion of the stump or the anastomosis. So that might be something to explore, but there's no evidence or data that is typically related to endometriosis surgery in that sense.
Gabi, we have a special Dr. Collinette Pierre is asking me to congratulate you for your presentation. It has been amazing, and to standardize the technique of robotic surgery. I think it's very important for all of us that we are considering to start with robotics. We are very experienced laparoscopic surgeons. I agree with you that laparoscopy and robotics is probably the same thing, but it's two different ways of doing the same thing. and it is important to have a standardization of all the steps that we need to perform before or during our way for changing to robotics. We are finishing. I have just one question. Is Pia, who say, try to convince a skilled 16 years of experience in laparoscopy, in standard laparoscopy, try to convince a skilled surgeon to change to robotics. Just one sentence, each of you, just for an experienced laparoscopy surgeon, why I have to change.
In one phrase, is that just
in one phrase? Yes.
It's just my take-home message. You don't know if you won't try.
Okay, Emil.
I don't want to be has-been compared to my colleague, and I have a big experience in laparoscopy. I want to be able to make some comment about a surgery performed by my colleague in my department. And I think it's a reason why I switch my activity from laparoscopy to robotic.
Okay, Gabi.
Well, my advice, if you're not ready to learn a new thing, then you can do robotic surgery and leave your ego outside and be prepared to be a learner again.
Okay, and how you foresee the future for robotics? Do you think the surgery, that robotics is the future of surgery or not?
Oh, yeah,
very quick.
Probably, maybe, hopefully, one more Seud will talk about the future, because the future is very exciting, as with technology. The incorporation of augmented reality and artificial intelligence in whatever we do is going to be the trend in the next 5 to 10 years. So I think the robotic platform is on the cutting edge.
Yeah,
I agree with you. Thank you. All
we
of
do
you.
not block technology.
No, for sure. We need to be open for technology. We need to be open for change.
Yes.
Probably our comfort zone is better in general, but if we don't go out of this zone, we never have progress. Thank you, all of you. I think just summarizing the main points, the main ideas of this symposium. Robotic surgery is perfectly, you can use it in robotic endometriosis without any problem. It has some advantages, very evident. The fact of the degrees of freedom of your movements is for sure an advantage, and we need to work a little more, because I think it's a sentence from Gabi. Laparoscopic robotic surgery in endometriosis is in the childhood, and we need to continue working and to continue working in this area. Thank you, all of you. Thank you to Intuitive for allowing the Seud to perform this webinar, and thank you for all the participants. I think it has been a very interesting webinar, and I hope to see you in the next Seud Congress that has been moved from end of May to beginning of December, also in Stockholm. I hope to see you in Stockholm in next December. Thank you very much, and have a good afternoon.
Bye-bye.
Bye.